Now we're going to start the discussion about the development of the midgut. So again, yes, this is the gut tube. This is the foregut tube, the midgut tube. This is the hindgut tube. The primitive dorsal mesentery on the back side. Now in the primitive dorsal mesentery, yes, we see the dorsal aorta. Now from the dorsal aorta, we have the artery. Yes, we know that. Celiac trunk, superior mesenteric artery and the inferior mesenteric artery. This is midgut, this is foregut, this is hindgut, this is our superior mesenteric artery. I hope you know this basic detail. So now we're going to draw the diagram for the midgut tube. Now midgut tube now with ventral convexity like this. Now this is our midgut tube. This is with ventral convexity. Okay. Now this is our vitelline duct. This is our vitalointestinal duct. No, that is our vitelline duct, and this is in turn in the umbilical vesicle. Now this is our abdominal cavity. This is our abdominal cavity. And this is our extra embryonic cavity. Extra embryonic cavity. So midgut loop, you see the ventral convexity. Why ventral convexity? Because midgut loop, because this is a midgut, this is the midgut, this is foregut and this is the hindgut. Because midgut loop, they herniate into the extra embryonic cavity, divided into extra embryonic cavity. Now why it is herniating into extra embryonic cavity? Because the midgut loop does not have the enough space to develop. The abdominal cavity is occupied by liver. The rapid growth of liver decreases the space for the midgut loop to develop inside the cavity. So now the midgut loop, it is coming out of the abdominal cavity into extra embryonic cavity. Now this is called physiological hernia. Now this is called physiological hernia. Now this physiological hernia occurs by 6th week. Okay. Right. Now, what is this? I'm drawing in red color, no? What is this? That is the artery. What artery? Artery of midgut, superior mesenteric artery. Now, the superior mesenteric artery divide the midgut loop into two parts. This is the pre-arterial segment and this is the post-arterial segment. So, we have pre-arterial segment and the post-arterial segment. So, please write the parts of midgut. We have pre-arterial segment and post-arterial segment. We have pre-arterial segment and the post-arterial segment. Now, the pre-arterial segment, yes, what are the parts in the pre-arterial segment? The remaining part of duodenum, below the ample of Vater. Duodenum, which is present below the major duodenal papillae, plus jejunum, plus ileum. Now what are the post-arterial segment? The terminal part of ileum. Plus cecum, plus appendix, plus ascending colon, and then the transverse colon right two-third. So these are our post-arterial segment, pre-arterial segment and the post-arterial segment. Okay, right. So now we know the parts of midgut loop. We are dividing the midgut loop by the artery, superior mesenteric artery, pre-arterial segment and the post-arterial segment. So now we have the mesentery here. Now we know that this is a mesentery, no? The primitive dorsal mesentery will be here. This is a primitive dorsal mesentery. The one which I am shading in the yellow color, that is the primitive dorsal mesentery. Now this primitive dorsal mesentery is going for thickening. The primitive dorsal mesentery, yes, it is going for thickening. The primitive dorsal mesentery, yes, which is going for thickening here. So now which in turn forms two band here. This is superior tension band and this is the inferior tension band. This is our superior retention band and this is our inferior retention band. Superior tension band, inferior tension band. Now what are these bands? These bands are nothing but they are the thickening of primitive dorsal mesentery. Okay, so now we're going to write about this retention bands. So now we're going to write about superior retention band. So superior tension band, I told you, inferior tension band, they are nothing but thickening of this primitive dorsal mesentery. Now the superior tension band, later it will form one remnant. What is that? Our ligament of Treitz or suspensory muscle of duodenum. Ligament of Treitz or suspensory muscle of duodenum. Suspensory muscle of duodenum. Now the suspensory muscle of duodenum or ligament of Treitz, which is extending from duodenojejunal flexure up to the right crux of the diaphragm. Up to the right crux of the diaphragm. Now what about inferior tension band? The inferior tension band will form the phrenicocholic ligament. So this inferior retention band, same story you have to say, thickening of the primitive dorsal mesentery, now which will form the phrenicocholic ligament. Phrenicocholic ligament. So suspensory muscle of duodenum, yes, derived from superior tension band, and phrenicocholic ligament derived from inferior tension band. Just know this detail, it is more than sufficient. Right. Now come here. Now this is our vitello-intestinal duct. So now this vitello-intestinal duct will disappear. So now this vitello-intestinal duct in 2% of the population, the proximal part of the vitello-intestinal duct persists. Now this is mesentery. Now this border is called anti-mesenteric border. Persist in the anti-mesenteric border. Anti-mesenteric border, and that in turn forms Meckel's diverticulum or ileal diverticulum. Okay, so the Meckel's diverticulum is nothing but the persistence of the proximal part of vitello-intestinal duct in the anti-mesenteric border. It is present only in 2% of the population. Now, the length measurement is 2 inches long. 2 feet situated 2 feet from the ileocecal valve. 2 feet from the ileocecal valve, which contains 2 types of tissue. One is gastric tissue and another one is the pancreatic tissue. So 2 types of tissue present, gastric and pancreatic. That's all about our Meckel's diverticulum. Okay. So now Meckel's diverticulum over. Next, we're going to discuss about the vitelline cyst or enterocystoma. Vitelline cyst or enterocystoma. Here, the both end of vitelline duct forms the fibrous cord, and the middle part forms a cyst. Middle part forms a cyst. That is our vitelline cyst or our enterocystoma. Okay. Now the both end will be forming the fibrous cord, and middle part, yes, we have the cyst. This is a vitelline cyst or the enterocystoma. Now next one, we're going to discuss about vitelline fistula. Now in the vitelline fistula or the umbilical fistula, vitelline fistula also called as umbilical fistula. Now here the entire length of vitelline duct remains patent. Now what will happen because of that? Because of that we have a direct communication. Because of that we have the direct communication between the umbilicus and the intestinal tract. So now what will happen because of this vitelline fistula, umbilical fistula? You will see the fecal discharge around the umbilicus. Fecal discharge around the umbilicus. The mother will bring the child to the OPD for the complaints of passing meconium around the umbilicus or fecus around the umbilicus. This is a recent question they gave in 2021 FMG exam. Yes, recent FMG exam they gave this question. So again chances are there to ask in the INACT exam or the NEET exam. So vitelline fistula is nothing but the entire tube remains patent, and thereby we have a direct communication between the umbilicus intestinal tract, and the baby will be passing the meconium around the umbilicus. Okay, right. That's all about the vitelline fistula. So now next we're going to see the rotation of midgut. Right, I told you just now the midgut contents, they are coming to the extra embryonic cavity. Why? Because we don't have enough space inside the cavity due to the rapid growth of liver. Right. There's a physiological hernia occurs by 6th week. Very good. Now this is the pre-arterial segment, and this is the post-arterial segment, and that is our vitellointestinal duct or vitelline duct. Now this is the cavity, say for example. Okay. Right. So midgut first rotate 90 degree in the counterclockwise direction or anti-clockwise direction. Okay. Now what will happen because of that? See the diagram here. Now they rotate in the anti-clockwise direction like this. So what will happen because of that? The pre-arterial segment going to the right side and the post-arterial segment come to left side. Pre-arterial segment goes to right side and the post-arterial segment comes to left side. Okay? Right. Now this is the artery. Now the superior mesenteric artery, yes, that will form the axis for the rotation. So first rotation over. Now we have the second and the third rotation. Now these two rotations will occur when this midgut loop enters into the cavity. So just now you told, sir, we don't have enough space for the midgut loop to develop inside the cavity. But now you are saying the midgut loop enter the cavity. Yes. Now after 6th week, now there will be the regression of the mesonephric kidney. So kidneys initially derived from pronephros and then mesonephros and then metanephros. So this mesonephric part of the kidney, that will regress, which in turn replaced by metanephros. Now the regression of the mesonephric kidney will create the space. Number 2, expansion of the abdominal cavity. The abdominal cavity will expand. Expansion of the abdominal cavity. And number 3, reduced growth of liver. Reduced growth of liver. Now these 3 factors, yes, which facilitate the entry of midgut loop into the abdominal cavity. The midgut loop can't present in the extraabdominal cavity for a long time. So we have to accommodate inside. Now what are the factors favorable for the return of midgut loop into the cavity, abdominal cavity? Regression of mesonephric kidney, expansion of the abdominal cavity, and the reduced growth of liver. Now because of this, the midgut loop enters a cavity. Now while entering, the midgut loop rotates 180 degree. So while returning, so already 90 degree rotation is over, plus while return into the cavity, the midgut loop rotates 180 degree. Again, pre-arterial segment 90 degree, post-arterial segment 90 degree, totally 120. So 90 plus 280, totally the midgut rotates 270 degree in the counterclockwise direction. Okay? Is that clear? Right. Now see the diagram. Now first rotation over. We know that. So already first 90-degree rotation over, and next 180-degree rotation will take place while returning into the cavity. Pre-arterial segment 90-degree, post-arterial segment 90-degree. 90 plus 90, 180. So altogether, the midgut loop rotates 270-degree in the anti-clockwise direction. Now, come to the diagram. Now, the pre-arterial segment elongates and forms the coils of jejunum and ileum. Because jejunum and ileum are very long loop, no? Yes, now the pre-arterial segment elongates and forms the coils of jejunum and ileum. Now see the post-arterial segment. In the post-arterial segment, you are seeing one bud there that is called cecal bud. Now cecal bud appearing in the post-arterial part at the 6th week. Okay, so first 90-degree rotation over. Because of that, pre-arterial segment come to right side, post-arterial segment come to left side. Now the pre-arterial segment elongates and forms the coils. In the post-arterial segment, the cecal bud will appear by 6th week. Clear? Now, the pre-arterial segment enters the cavity. Now we have a space inside the cavity because of the 3 reasons I told you. Regression of the mesonephric kidney, increased space of the cavity, decreased growth of liver. Because of that, we have a cavity. Now the midgut loop enters the cavity. Who will enter first? The pre-arterial segment enters the cavity first. The pre-arterial segment enters the cavity. Now while entering, the pre-arterial segment rotates 90-degree in the anti-clockwise side. AC in a anti-clockwise direction. See the diagram here. So the pre-arterial segment, see here, it is rotating in the anti-clockwise direction like this. Now segment is present here. Now because of this rotation, now the pre-arterial segment comes here and try to enter the cavity. See, some part are entering into the cavity. Is that clear? The pre-arterial segment rotates 90-degree. Now because of that, now the pre-arterial segment, this is pre-arterial segment. Now this is the pre-arterial segment. Okay. So pre-arterial segment enters a cavity and rotates 90-degree in the anti-clockwise side. Now what is happening because of that? Now the artery will be here. This is our superior mesenteric artery. I told you superior mesenteric artery is the axis for this rotation. Now the pre-arterial segment is present below the superior mesenteric artery. So after this rotation, the pre-arterial segment present behind the superior mesenteric artery. Very, 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 very important point. Okay. Now next point. See the post-arterial segment here. Now this is the post-arterial segment. Now the post-arterial segment enters the cavity. Post-arterial segment enters the abdominal cavity. Now while entering, the post-arterial segment rotates. How many degrees, sir? 90-degree. Which direction, sir? Anti-clockwise side. See here, this is post-arterial segment. Now this segment rotates in the anti-clockwise side and enters the cavity like this. See the diagram? This is the post-arterial segment. So post-arterial segment rotates 90-degree and then enters a cavity, and then yes, which in turn forms the adult relation. So now post-arterial segment enters a cavity, while entering, yes, rotates 90-degree in the anti-clockwise side. Is that clear? Over. So 90 plus 90, 180, already 90, so totally 270-degree in the counterclockwise direction. Right. Now please write. Now after completing 270 degrees rotation in the anti-clockwise side, now the cecum is present. The cecum is present just below the liver. Present below the liver. So now what will happen? the cecum will descend to right iliac fossa. So while descending, then the large intestine, which in turn differentiate into the various parts of colon, and also the appendix formed, and also the appendix developed. Okay, right. Now this is about the rotation of the midgut. Right, that's all about the rotation of midgut. Okay, so we have prearterial segment and the postarterial segment. What are the prearterial segment? Duodenum, jejunum and ileum. What are the postarterial segment? The terminal part of ileum, cecum, appendix, ascending colon, right 2/3 of transverse colon. Over. Now which structure is forming the axis for rotation? Superior mesenteric artery is forming the axis for rotation. First rotation in the anti-clockwise direction. Because of that, the prearterial segment goes to right side, postarterial segment come to left side. Now the prearterial segment elongates and enter the cavity first. While entering the cavity, which rotates 90 degrees in the anti-clockwise side, now because of this, the prearterial segment present behind the superior mesenteric artery. Third, the postarterial segment enters the cavity, while entering the cavity rotates 90 degrees in the anti-clockwise side and complete the totally 270 degree rotation. Now we're going to see some animation for the gut rotation. Yes. Now see this animation. Now we are seeing the midgut loop. Now we're going to zoom this region. Now we are seeing the prearterial segment, postarterial segment and the artery. Now first rotation in the anti-clockwise direction. So prearterial segment goes to right side and the postarterial segment come to left side. Okay, over. Now second rotation, the prearterial segment enter the cavity first. So it undergoes another 90 degree anti-clockwise rotation, entering the cavity now. Now the postarterial segment undergoes another 90 degree anti-clockwise rotation while entering the gut. The third 90 degree anti-clockwise rotation by the postarterial segment. See? And enters the gut. Now the cecal bud is just below the stomach, subpyloric cecum, and now the cecum will descend down into the right iliac fossa, which in turn forms the different parts of colon. We have ascending colon and then transverse colon, and the other parts of colon are formed. These are some basic animations about the rotation of midgut. Now we're going to discuss certain anomalies here. Now first, omphalocele and the gastroschisis. Now what is omphalocele? What is the gastroschisis? Now the physiological hernia will occur by? Physiological hernia occurs by? Very good, 6th week. Now when the reduction will take place? The reduction of physiological hernia will occur by 10th week. Physiological hernia 6th week. Reduction of physiological hernia by 10th week. Okay. Now if the physiological hernia fails to reduce, then that is called omphalocele. So omphalocele, please write the physiological hernia fails to reduce. That is called omphalocele. Now next, gastroschisis. So gastroschisis is nothing but it is a hernia at the weak point in the abdomen. At the weak point. Now what is the weak point? We know that the right umbilical vein will disappear. We have only left umbilical vein. So right umbilical vein will disappear. One hernia will occur at the site of regression of right umbilical vein, and that is our gastroschisis. So gastroschisis is nothing but it is a hernia at the site of regression of right umbilical vein. Now next one. In the omphalocele, now you are seeing the sac. Yes, the sac is present. Now whereas in the gastroschisis, do you see any sac here? No, sac is not seen. Sac is absent. Number 3. Now what are the contents present here? Initially, yes, the small intestine is present. But later, any organ can present inside. So initially intestine will be there. but later liver, etc. Any organ present inside the sac, any organ. Whereas in the case of gastroschisis, only intestinal loops seen. Only intestinal loops present. Now because of that only, the intestinal obstruction is most commonly seen here. Intestinal obstruction is the most common feature of gastroschisis. Okay. One last point, omphalocele associated with the other congenital anomalies. Associated with other congenital anomalies. Whereas gastroschisis, no, which is not associated with any other congenital anomalies. Okay. So gastroschisis is not associated with any other congenital anomalies. So these are the points you have to know about omphalocele and gastroschisis. So now we're going to start the discussion about rotational anomalies. Okay. Now first one, non-rotation. In non-rotation, the first 90-degree rotation in the anti-clockwise direction is normal. Now because of that, the pre-arterial segment occupies the right side and the post-arterial segment occupies the left side. Now without any rotation, the remaining 180-degree rotation will not take place. So now the pre-arterial segment enters a cavity and occupies the right side. The post-arterial segment enters the cavity and occupies the left side. So in non-rotation, the pre-arterial segment found on right side and the post-arterial segment occupy the left side of the cavity. So your diagram, pre-arterial segment, post-arterial segment. Pre-arterial segment forms the right side. So the small intestine forms the right side and the large intestine on the left side. Okay. Pre-arterial segment right side, post-arterial segment left side. That is a feature of non-rotation. Now second one, incomplete rotation, which is otherwise known as mixed rotation. In the mixed rotation, the first 180-degree rotation will be normal. The last 90-degree rotation will not take place. Okay, that is the feature of our mixed rotation. Now, in this, the cecum is found just below the pylorus, subpyloric cecum you will see. So in the non-rotation, you will see the subpyloric cecum. Cecum is present just below the pylorus, and we also see one band here. That band is called lattice band. That is our lattice band. Lattice band is crossing the duodenum anteriorly. That will compress the duodenum, which in turn produce duodenal obstruction. So please write the features of the incomplete rotation or the mixed rotation. Number 1, subpyloric cecum. Number 1, subpyloric cecum. Okay, sir. Number 2, you will see the lattice band. Lattice band, yes, that in turn compress the duodenum. Lattice band that will compress the duodenum and the baby will have duodenal obstruction. Now what will happen because of that? The baby will be having bile vomiting, very important feature. So if you see any newborn with bile vomiting, then please remember that is due to this only. That is due to our mixed rotation. Newborn with bile vomiting means, yes, please think and come to the diagnosis and refer the patient immediately to the pediatric surgeon. That is the case of the mixed rotation. Okay? Right. Now next one, the reverse rotation. Now with the reverse rotation, the first rotation will be in the clockwise side. The first 90-degree rotation will be in the clockwise direction. Now what will happen because of that? The superior mesenteric artery will compress the transverse colon. See here, this is superior mesenteric artery compressing the transverse colon. Normally, superior mesenteric artery, yes, which is passing behind the transverse colon. But here, in the reverse rotation, the relation is ulta, opposite. So, superior mesenteric artery compress the transverse colon. Is that clear? Right. That's all about the rotational anomalies. So, midgut rotation, yes, very simple topic. Yes, so many applieds are there and very important module for the PG entrance exam and also for first year MBBS. So, in the midgut rotation, we have to remember about the rotational anomalies. Sometimes we are getting question about omphalocele in the gastroschisis, and very often we are getting questions about Meckel's diverticulum, and recently they gave the uterine fistula. Okay, yes, very important module we completed.